Hello everyone, thank you so much for helping out. My name is Ryan Suminima. I'm a radiography fourth year student, studying in Nigeria, and apart from my medical studies in radiography, I'm also a proficient medical writer and also YouTube content creator. So today's an amazing day. I have an amazing guest speaker all the way from the UK. Hey, Remi, could you introduce yourself to the audience?
Yeah, sure. My name's Remi. I am an obstetrics and I'm a gynecology registrar. I've been doing that now for 8 years, and I've been a graduate. I've been a working doctor for 10 years. Alongside that, I'm very passionate about women's health education, and I'm a co-founder of Neara Health, which is a women's health education platform, which the main mission is to combat misinformation online, empower women with education, and hopefully help them advocate for themselves and their community. So yeah, so that's a little bit about me.
Amazing. So before I move further to the questions we have for you, Remy, when you talked about the women's health, are there particular health related specialty you're in terms of the women's health, or is it a general health you're talking about in terms of the women?
So when we speak about women's health, it is a blanket term because it doesn't necessarily describe what you're after. But where I work in obstetrics and gynecology, I'm dealing with women's reproductive health, their health during pregnancy, after pregnancy, gynecological conditions, cancers in the later life, menopause. So those are the types of things that I see within my clinical practice. And that's what I'm talking about when I talk about women's health, because of course you've got things like breast health, mental health, other organs, and it's not just, women are not just reduced to their gynecological organs. Yeah, so thank you for clarifying.
Yeah, I just had to because of the audience. So the first question for you is, what misconceptions about women's health do you often encounter in your practice? Talk us through.
Oh, so many. I think so. When I'm clinically working and women come to me in the gynecology clinic, for instance, I will often recommend the hormonal contraceptives, but use them as treatment. And a lot of women that I encounter are like, oh no, I don't want to use this because I've heard of so and so online. I've heard it can affect my fertility. I've heard it can, stop me from ever having babies in the future. It can cause cancer. And all of these things are myths and stories that we've often picked up online. And I always try within my clinical setting to try and combat that and discuss how that is the case. If you go down the sort of sexual health route, some people mistake what sex is, and they might say, oh, I'm not sexually active. And actually, when you dive down, you're like, oh no, but whatever you're doing can still cause you to be at increased risk of cervical cancer. So it's not a reason to miss your screening. And many, many more in pregnancy. Oh, I can't take paracetamol in pregnancy. It's not good for the baby. So there's so many misconceptions around all the work I do. And I find that sometimes when you just have conversations with women, then you can really die down, like, where did you get this information from? And actually, can I provide good education to combat the misinformation that you have?
Okay, so I totally understood what you just said. We the math students, we're really curious about some things. So I want to ask you a question before we move to the next question for you. When you talk about breaking the breach in terms of the misconceptions about women's health amongst women, during your practice, right? Are you breaking the breaches through word to word with the patient, or is there other means you're using apart from your practice to break that misconceptions about women often encounter in your practice? Tell us.
So yeah, I think there are many ways to combat misconceptions or myths or misinformation. And when I'm face to face with a woman, that's the easiest time to have a two-way conversation. Other ways I've done it in the past is on our Neara Health Instagram page. We publish bite-sized educational content, which I think is useful, but sometimes the context is lost and the two-way conversation is lost. And then on top of that, I'm always recommending women to go to reputable websites or peer-to-peer support groups, because again, you can almost trust that that information is somewhat sound. But again, you kind of lose the two-way conversation. So my preferred method is to actually meet women, have a conversation with them. But there are definitely other ways in which these misconceptions could be countered. On a public health level, you can do it with education through the schools. But again, you need that two-way conversation with the population, with the client, with the woman, to make sure that you're really dialing, you're really challenging sometimes some entrenched beliefs, especially with the fertility one. Like, I'm British born, but Nigerian by background. And growing up, even within our circle, it was like, oh, don't use contraceptives. It will affect your fertility. You'll never be able to have babies. And so when those medications are offered for treatment, there's a reluctance to use them because you're really worried, oh my gosh, my fertility, and things like that. And also just understanding about female anatomy, because again, I had a patient recently. We were doing a fairly straightforward procedure for her. And on the day of the surgery, she said, will this affect my fertility? And I said, oh, no, not at all. We're not even going anywhere near your ovaries, nowhere near your womb. And you just think, oh, yeah, if the basic understanding of anatomy was there, although it's a very sound question to ask, you would know that those things wouldn't impact it. So, yeah.
During my clinical rotations at one of the diagnostic, laboratory services I work with, hospitals I work with, our chief, we radiography students, we call our colleagues already working in the profession chiefs, right?
Yeah.
They told us that with that anatomy, you can't do anything special on the patient. For instance, what I mean by special is when you talk about radiography, you have a special radiology examination called SSG. SSG is hysterosalpingogram, which is a fertility test done on a female patient, to check the womb, the fallopian tubes, the uterus, the patency of all those reproductive systems in the female. So without the knowledge of anatomy, I don't think one can do all the spatials. For instance, it also partakes to your practice. So that's why you need to get grounded in terms of anatomy in case of other medical students that watch this video. Learn how to get married with your anatomy, because without your anatomy, you can't go further. In terms of your practice, in any medical practice. So yeah, thank you so much for sharing that with us, Remi. The second question for you is, how do you discourse reproductive health, such as birth control and family planning, with your patient? Talk us through.
Yeah, so again, it always depends on the motive of the patient. So in the fertility clinic, if a patient comes in, she says that she's been trying to conceive for a year or 2 years, the first thing I want to know is, okay, but how often are you having sex? How often are your periods? And from those two questions, I can almost determine if there's a true problem that needs further investigation or not. So a lot of women say, oh, I've been trying for 2 years. Okay, but how often are you having sex? Oh, maybe once a month. And then you're going to have to counsel them on the fact that actually, if you're truly trying to conceive, what is recommended is you're having sex 2 to 3 times a week, and you're doing that consistently for about 6 months or a year. Like in the UK, because we have the National Health Service, we often recommend that you get investigations after a year. And if the National Health Service is able to pay for you to have fertility treatment, they would want you to be trying for 2 years. And the evidence is that actually 90% of couples, if they try 2 to 3 times a week for 2 years, they'll conceive at some point. So that's kind of where I would go in a discussion from that point of view. And that's where the education comes in. If, for instance, they're trying not to conceive and they're having unprotected sex. So another question I like to ask women is, are you on any contraception? No, I'm not, doctor. Okay. Are you currently sexually active? Yes, doctor, I am. Okay. So are you trying to get pregnant? no, doctor, I'm not trying. And I'm like, that doesn't add up. If you're not trying to get pregnant, then you should be actively using contraceptive or birth control. And that can be the hormonal ones that I kind of alluded to before. It could be the barrier ones like the condoms and the diaphragms and things like that. And it could be non-hormonal. So yeah, so whenever I'm trying to get through to what a patient's agenda is when they come to see me, my questions are very much based on what is it that they want and what do they understand about their actions that can either give them what they want or give them what they don't want. And that's how I frame those conversations.
Wow, amazing. Thank you so much for sharing that with us, Remy. But before I move further, there is one question I want to just skip in for you. Um,
Mm,
yeah, I was speaking with one of a urologist,
mm.
with over 30 years of experience in the US. And it seems that the kind of works you do, at your own department is kind of like synonymous with the works urologists do.
Oh,
So
yeah.
could you, in your own perspective, could you little differentiate the difference between your work and the work of a urologist? Because you guys kind of like do the same thing. You guys, they also talk about family planning on the patient. So
Oh,
could you
okay.
just, yeah, take us through?
Yeah. So as I've been an obstetrician and gynecologist for 8 years, I've not treated a biologically male patient like in the last 8 years, in the sense that obstetrics gynecology is very women focused, whereas I did a urology job actually as a house officer, and they do have some female patients, but again, I think the majority of their patients are male, but they're dealing with issues of the bladder, and issues of passing urine. And obviously with men there's a little bit of crossover in terms of um, like family control or birth control. And actually, when a urologist sees a female patient, they do need to take into account if they're trying to get pregnant, how many children they may have had in the past, because some of the treatments will interact with that. But again, they're focused mainly on the bladder. There is a crossover specialty. It's called urogynecology, and I've only come at it from the gynecology point of view, where you have women who have like leaky bladders and you initiate treatment to help sort out incontinence, or if they have like bladder pain syndrome or repeated urine infections. That's where there's overlap. But for the most part, I would say that there's slightly different specialties, just both working in the same general area of the patient. My patients are predominantly female, and their patients should be mixed, but again, they have a tendency to have male patients.
All right, that was amazing, Remy. Have you ever referred your patient to a radiographer for SSG radiology examination of the patient?
Yeah. So definitely with the fertility patients, coming back to those, once you've established that actually this person's been trying for a while and they are not conceiving for whatever reason, you then need to determine what are the causes of the infertility. So we know that the tubes which come off the womb that connect to the ovaries, they can be a reason why women aren't getting pregnant. And the HSG test is to check that the tubes are open and that they're structurally sound. So sometimes you might get that, the tubes look over dilated, or you're putting so you put like injector dye into the womb and it should go through the tubes, and you should see at the base of the tubes that the tubes are open, or at the tip of the tubes that the tubes are open. And that's what the HSG is for. And if that works well, then that satisfies our judgment that actually the tubes are open. Sometimes that test is inconclusive, and then the women then need to go on and have a surgical procedure where we're doing pretty much the same thing, but now we're looking in the tummy with like keyhole surgery to see that the tubes are actually open. So yeah, so typically as part of our fertility workup, we need to check the tubes, and the way that we're definitely doing it in my unit is to do it with the HSG.
Amazing, amazing. All right, so the next question for you is, um, so before I ask you this next question, talk us through
Mm.
about your company you founded. Tell us more about your company.
Yeah, so I'm a co-founder. So myself and my friend and colleague, we obviously living in the UK, we're very aware that there are health inequities worldwide, you know, between the global West and the global South, but also just within the UK, within London where we work, we were finding that actually women who are from non-white background or slightly poorer background, they would come to hospital with a little less knowledge about their health. They wouldn't know the right keywords to say to get the right treatment sometimes, and they couldn't advocate for themselves. And the flip side to this is we know that there's medical racism, we know that there's bias, we know that the system doesn't favor that group of women. So we thought, how can we, within our own sphere of influence, make a change? And we felt actually, if we gave the women the right keywords, the right type of knowledge, the right way to advocate for themselves, could they go into those appointments with more information and be able to make a decision that they've chosen to improve their outcomes? And even if they encounter medical racism and systemic bias, can they slightly dim the effects of those just by knowing a little bit more? And then on the flip side, we do like to go in and teach our colleagues about the effect of racism and bias and unconscious bias on our patients. And can we just encourage them to do things, again, within their small power and sphere of influence to improve the care for those women? So yeah, so that's our aim, and that's what we do.
Amazing. Thank you so much for talking us through about the company, how it works, So that draws me to the next question for you. So what are the most important lifestyle factors women should consider for optimal health? Talk us through.
Yeah, so I think my answer to that is multifactorial. So if you think about health in general, health is the absence of disease, but also like you're thriving and things like that, and you're able to make decisions that positively influence your life. When I think about my specialty and I think about women defining health, there's some women defining health as the ability to have a baby. So if I see a woman that wants to have children and is not able to, the effect on her mood, on her quality of life will lead to her being in poor health. And is there anything that a woman in her younger years can do to improve her fertility, and the lifestyle factors around that would be just to have safe sex. So use contraception, and if you're not using barrier contraception to prevent against things like chlamydia, gonorrhea, make sure that you're getting those diseases treated on time. So regular sexual health checkups, because we know that if you have had a sexually transmitted infection, especially if it goes untreated, it can damage the tubes, and then that can cause the tubes to be damaged, increase your risk of a pregnancy in the wrong place or not being able to get pregnant at all. So that would be one train of thought. And then if you think about good health being like, actually you get pregnant, you can sustain a pregnancy, you don't get things like high blood pressure, diabetes. We know that that's linked to your weight, your body weight prior to getting pregnant, and during the pregnancy as well. So then that would be eating healthily, losing weight, exercising regularly. And the benefit of exercise also, not just for pregnancy or for the time after, but for the time of the menopause. When you're exercising, you're increasing your bone density. So then when you're in the time of the menopause, your body's strong enough to take you through that time when your hormones are not there anymore. So safe sex, exercise, eat the right types of food. Those are like my barn door sort of lifestyle advice that I give to women. I'm sure there are many more, but those are my main three.
Yeah, I believe that women out there that are watching this video should looking forward to living an optimal health. Should abide to those nuggets Remi shared for us. So the last question for you, Remi, is: in your experience, what are the best strategies to improve women's health and education in the society? Tell us.
Yeah, that's a big question. At a society level, what are the ways in which to improve it? I think it needs, again, multiple hands, right? So as an obstetrician gynecologist, I will know my bits. My general practitioner colleagues will know their bits. radiographers will know their bits, and anyone who works in health would know their bits. But then you need the teachers, you need the mums, you need the dads, you need a concerted community level change as well. You need the religious organizations to take part or to promote positive and fact-based and evidence-based information. And all of those things, once they come together, produce an effect of progressive education for women. And it needs to start from a young age. It needs to start in the schools. It needs to start with them knowing the right words for the body languages. It needs to start with the guys as well, the boys in the class, knowing what the period is, when it happens, its effect on women, what can constitute sex, what, you know, there are so many things that I think that as women, especially as an obstetrician, that I learned within my field of work, that I just wish was general knowledge. And I think the easiest way to do it is through schools. But alongside the schools, you need the community level change, and then you need public health strategies, you need the workplace to change, and then you need more women to get in front of clinicians and experts with evidence-based information.
You know, Remi, you've been an amazing guest speaker thus far, and I believe that the audience, will greatly adore you, for sharing your narratives on these questions. And I could remember when I was in my first year, and that was in 2020, like first year in my radiography school. I could remember whenever we talk about things related to reproduction, women's health, we get really shy sometimes, we're really shy to talk about all these things. But right now, it's just a normal thing for us right now because we founder level now. So I've seen where they're doing SSG examination on the patient. I've seen a lot of examinations that are really, when you see them, you just shiver, But it's just a normal thing for us, and I believe that what I'm doing is gonna help because why the reason why I'm working so hard, learning so hard is because lives are in my hands, right? In Nigeria or in Africa, I don't know about other continents. There are misdiagnoses really happening in our society. So that's what I'm really working at, so they can bridge all those gaps and help people and also save lives as well. So you've been an amazing guest speaker, Remi, and the audience and me, we really appreciate you. So before we wrap up this session, what are your last words for the audience?
Yeah, no, thank you so much for having me. It was a great chat. I think my last words for the audience are, if you're a clinical student and you're interested in obstetrics or gynecology or anything, even just saving lives, which is what you've just said, I think it's really important to learn your craft, but to bring people along. Like, I think it's very easy sometimes to just stick within your job, but we actually need to go beyond. We need to go beyond the hospital walls. We need to go beyond our patient interactions and genuinely make change to how people interact with their health, either on a society level, community level, or individual level. And my motivation to people is to just do your small part, to just push the humanity forward, push education of health forward in any way that you can. And I think it's a great job to be able to serve women. I personally believe so, but I can imagine for other specialties to just serve people and to have a higher purpose to your job. So I hope that's what you gathered from this, as well as all the little nuggets of advice that I snuck in about women's health. But yeah, no, definitely. Thank you so much for having me. And I look forward to watching this back, but also your other productions.
Absolutely. So if you love this content, do well to subscribe, like, and share to your network, and hopefully so your network will really adore this video. Thank you so much.
Thank you.